Good morning, everyone. And this one is another topic for diagnostics. And in this lecture, we are going to discuss, going to start with thyroid hormones or diagnostics of thyroid conditions. And as particularly we are discussing lab diagnostics, so we will just about talk about the lab results, right? And we are going to talk about thyroid, we are going to talk about diabetes, we are going to talk about adrenal hormones, we are going to talk about multiple endocrinological conditions. So, the important thing here is what, first of all, is again the basics. We must know uh, the basics of all the functionality, how the hypothalamus, pituitary, and you can say the gland axis work. For example, in this case, the thyroid hormone, how the hypothalamus, pituitary, thyroid axis is going to work. So the understanding of that thing matters a lot in understanding how the negative feedback mechanisms they play the part in controlling the level of hormones in the body, and what kind of negative feedback mechanisms or what kind of hormones have what kind of action. So, to start with, generally speaking, if we will discuss about endocrinology in the start, all the disorders or endocrinological disorders, um, they are classified or they can be divided in into into primary and secondary disorders, or you can say the primary endocrine disorder as well as the secondary endocrine disorder. So what happens, like we call any endocrinological condition as primary endocrinological disorder when the pathology or the problem is uh, is in the gland itself. For example, um, primary hyperthyroidism means what? That the problem is in the thyroid gland itself. Okay, and we say secondary when basically the problem is um, secondary to something, or you can say is due to some other condition. Uh, now, it is not just about primary and secondary because there is tertiary as well. Uh, Especially, like, there is um, primary hyperparathyroidism, there is secondary hyperparathyroidism, and there is tertiary hyperparathyroidism. So of course, like I'm going to discuss the tertiary causes once we are going to move on onto the things. The important thing over here is what, as I told you, I gave you the example of thyroid gland. When someone says primary hyperthyroidism, it means the thyroid gland is overactive and it is producing a lot of hormones. When we say, for example, secondary hyperthyroidism, which means that the pathology is not in the thyroid gland, rather it's the overproduction of some other hormone which is stimulating thyroid gland more and more. In thyroid case, for example, the problem can be in pituitary. Why? You can understand by this thing. I'm going to show you simple photographs, not putting you in so much what you can say um complications. A very, very, very simple um, type of photograph you can see over here. What's going on? You know, thyroid hormone is such a hormone that it affects almost every cell of the body. And it is your metabolic rate, which is basically um, uh, controlled by or defined by the thyroid hormones. Now, you can see in this case, hypothalamus is forming thyroid releasing hormone, and when it is released, in response to that, the pituitary, it forms thyroid stimulating hormone. And as the name shows, the thyroid stimulating hormone is going to act on the thyroid, and the thyroid is going to make the thyroid hormones T4 and T3, which will go into the bloodstream and which are going to act on different cells of the body. Now, when the T4 and T3 levels are going to raise in the body, there will be negative feedback mechanism, like negatively they will inhibit the release of TSH as well as TRH. So now when the pathology is here, we call it as what? Primary hyper or hypothyroidism. But when the problem is not in the gland, rather somewhere else, so we can, like in pituitary, we can call it as secondary hyper or hypothyroidism. So normally thyrotropin releasing hormone TRH is released from the hypothalamus, and it stimulates the pituitary gland, which releases the thyroid stimulating hormone, and this hormone then acts on the thyroid gland and results in the release of T4 and T3 into the circulation. And these hormones exert the negative feedback on the hypothalamus as well as on the pituitary and result in reduction of the level of TRH and TSH. So now one important thing, so like this is like the basics things, right? So now of course you must know what are the functions of thyroid hormones, how they act on the cells. Our discussion is not that. So now thyroid hormone. Um okay, now we know that there is one thing called STRH, which is thyrotropin releasing hormone, and now we know that there is another hormone called as TSH, or the thyroid stimulating hormone. Other than there is T4, and other than that there is triiodothyroxine. Okay, these are all the hormones which play a role. Now, this T4 and T3, which are basically present in the circulation, they are carried in the body or in the blood by a carrier protein, and that protein is called as thyroid binding globulin, or you can say TBG. Okay, so and a very small, most of the T4 and T3 are bounded form, and very small percentage of these hormones are in unbound form, and the small percentage which is uh, in unbound form, basically that one is the active one. Okay, or like that is the one um which is going to which is physiologically active, which is going to bring the change, increase the um do their action on the cells. So now in clinical practice, what we do, like normally we measure TSH, T4, and T3. Okay, and sometimes you can get the results like this. They are going to give you the total T4 uh, with both the bounded form and unbounded form as well. Okay, so this they give you the results of both, like how much is the bounded and how much is the unbounded. Not always, but sometimes. Okay, that one is given. So going back to the normal, the same diagram, I hope you understand this one, right? Quite easy, by the way. There is nothing like complicated in this one. Now, for example, I will start discussing hyperthyroidism, right? Hyperthyroidism. So, as the name shows, hyperthyroidism means what? The level of the thyroid hormone in the body is increased, right? See, uh, what happens? One of the condition which causes hyperthyroidism is basically Graves' disease, right? Um, okay, you can see this one. Again, a very simple chart, and we are talking about this one, Graves' disease. Now, Graves' disease is an example of primary hyperthyroidism. What it means, the pathology is in the thyroid. That's why it is called as primary hyperthyroidism. So, which means that the thyroid gland is actively forming more and more thyroid hormones. So, now the pathology is here, and which means like the thyroid is not under the control of pituitary. No matter the TSH is there or not there, thyroid is working on itself. So thyroid will keep on making T4 and T3, and T4 and T3 are going to go back and negatively feedback hypothalamus as well as the pituitary. But as I told you, normally clinically we measure TSH. So what is going to happen, that due to increased level of T4 and T3, and of course it is hyperthyroidism, so which means the level of T4 and T3 in the body, in the blood, will be raised. Okay, so when we will do test, we'll found like these levels are increased. Now as these levels are increased, there will be negative feedback mechanism. So what will happen, they are going to stop the pituitary and the hypothalamus to stop making TRH and TSH, and clinically most of the time in daily practice we measure TSH. So what will happen to that level of TSH in primary hyperthyroidism, or I gave the example called as Graves' disease? T4 and T3 will be high, but due to normal negative feedback mechanism, because this mechanism is still normal, there will be very less level or low level of TSH. Okay, so see here, in Graves' disease or toxic thyroid adenoma, like there is a tumor in the thyroid, or toxic multinodular goiter. Toxic means like there is overproduction going on. See what will happen to the level of free T4 and T3. They will be higher, and due to their normal feedback mechanism on the pituitary, the TSH will be low, right? Okay, now I'm not going to put you guys in more details other than this, because I think, like, I believe right now it's important to make such concepts, right? Because when you will study Graves' disease, and you would come to know that Graves' disease is an autoimmune condition. And what, when I say autoimmune condition, which means like there is immunities keep on making auto antibodies. So these auto antibodies are going to act on the thyroid, and they will keep on stimulating the thyroid gland, and the thyroid gland will keep on forming more and more T4 and T3. So of course, like, once we get the levels of uh, thyroid hormone in the patients, then of course we go for what you can say further testing. Like in Graves' disease, we are going to check for the antibodies, or for example in case of toxic thyroid adenoma or toxic multinodular goiter, what we are going to do, we are going to look for the structure of the thyroid by doing some scans, imagings, or a test called as radioactive iodine uptake, in which the adenomas which are hyperfunctioning, or that's why they are called as toxic multinodular or toxic thyroid adenoma, they are going to take more and more iodine. Like, if you know, like the thyroid hormones, they are formed by iodine. So a very simple concept, guys. Very, very, very simple concept. The thyroid gland produces thyroid hormone. So in this case, in hyperthyroidism, the level of T4 and T3, of course, are going to be raised. Okay, in the blood, and once these levels are going to raise in the blood due to normal feedback mechanism, the level of TSH will be low, and that's why we get these results. Okay. By the way, there is a condition called as isolated T3 thyrotoxicosis. What happens in this one? Maybe T4 will be normal as well, but the T3 is higher. So now I will tell you, for example, what is going to happen in secondary hyperthyroidism, right? So simply secondary hyperthyroidism. Hyperthyroidism. So what's happening in secondary hyperthyroidism? For example, it is going to cause due to a tumor in the pituitary, or for like we can say pituitary tumor, which or a TSH secreting pituitary tumor. TSH secreting secreting pituitary tumor. So now what's going on? See, there is a tumor over here. Now that tumor will keep on producing TSH. That tumor will keep on producing TSH. The TSH will go to thyroid, keep on stimulating thyroid hormone gland to produce more and more hormones. So the level of T4 and T3 will be increased. T4, T3 will go through the negative feedback mechanism, is going to suppress both of these. But what's going on here? There is a tumor which is now not under the control of this negative feedback mechanism. So no matter what is the level of T4, T3, the pituitary will keep on making TSH. The pituitary will keep on making the TSH. And that's why this is the example of secondary hyperthyroidism. And I gave you the example of TSH secreting pituitary tumors. What will happen to the level of T3, T4? The level of thyroid hormones, which are T3 and T4, will be high. It is hyperthyroidism. But what will be happen to the level of TSH? The TSH levels, which should be normal, which should be low in primary hyperthyroidism, it will be either normal or high. Okay, so practically speaking, when there is too much hormones, of course, the TSH should go down. But in this case, it is going to be high or normal. So now, see, this is a very, very important point to remember. Whenever you found, for example, a normal TSH level, in the settings of raised T3 and T4, it should raise the suspicions of what? Pituitary lesion. Because in the normal circumstances, when the T3, T4 level in the body is high, TSH should go down. But in this case, either it's normal or either it's high. So remember, the pathology is in the pituitary, right? Same thing, guys, I will talk about hypothyroidism. So see, like the thing is not so difficult, rather very, very, very simple. So what will happen in hyperthyroidism, in hypothyroidism? Again, I'm going to bring the same slide. Now, if you will see over here, they have given over here a condition called as Hashimoto's thyroiditis. Now, in Hashimoto's thyroiditis, again, it's a condition which is caused by auto antibodies. Okay, but in this case, what's happened? In the start, the thyroid go into the hyperfunctioning state, but later on, the thyroid gland become defective, and when the thyroid gland become defective, thyroid gland is not going to make any more T3 or T4 in the blood. So what will happen in hypothyroidism? Okay, for example, this one here I discussed. This one is primary hyperthyroidism, and this one is primary hypothyroidism. So remember, it's hypothyroidism. So whenever it is hypothyroidism, guys, so remember this thing, that in hypothyroidism, what should happen to T3 T4 level or thyroid levels. So the thyroid levels or thyroid hormone levels uh, will be low. Okay, why? Because clinically the patient is in hypothyroidism. So what is going on? The thyroid cannot make the hormones. So when the thyroid cannot make the hormones, so what is there? That the pituitary is going to, you can say, in hyperfunctioning state, right? Because the pituitary will sense, okay, there is no thyroid hormones in the body, so it means we must produce more and more and more TSH, which should produce more and more, like the thyroid should produce more and more thyroid hormones. So in this case, in primary hyperthyroidism, TSH levels will be high. So you can see over here, Hashimoto's thyroiditis, T4 and T3 levels are low, but which levels are high? TSH levels are high. Now, why? Because see, the negative feedback mechanism loop is intact, okay, and that's why TSH will keep on coming more and more and more, right? Whereas, if you will see what is going to happen in hypothyroidism, or this one is the primary one, right? Primary one. What will happen in secondary hypothyroidism? Hypothyroidism. What is going to happen in secondary one? For example, now there is a destructive tumor in pituitary. Okay, what is destructive tumor? Of course, like simply, it's a tumor which have destroyed the pituitary, and the pituitary cannot make any hormone. So, which hormone pituitary cannot make? Of course, the TSH hormone the pituitary cannot make. So in primary hypothyroidism, the pituitary hormones, or you can say the TSH level, remains high. But in this one, the pituitary is having pathology. So the TSH cannot be produced by pituitary. So the TSH levels will be low. And at the same time, when there is no TSH, the thyroid cannot make any thyroid hormone. So the thyroid hormone levels, which is like again T3 and T4 levels, will be low as well. Okay, so this is how primary hyper and hypo and secondary hyper and hypothyroidism, they play the role. Okay, so there is something called as sick euthyroid syndrome. What they say, like, we must be very cautious or must be very careful when we are interpreting thyroid function test in the patient with acute illness, because remember this thing, that thyroid, okay, what I'm talking about is sick euthyroid syndrome. Okay, what happens? uh, THYRY, okay, sorry. Okay, what happens, like, remember, um, in acute phase of illness, of any illness, okay, what happens is simply, um, you can say, uh, the thyroid function tests, or TFTs, are usually abnormal, okay, or are mostly abnormal, you can say. But like, the good thing, once that illness is gone, the thyroid test, or the levels, they come back as normal. Okay, basically this phenomena is called as sick euthyroid syndrome. Okay, and why it is called as euthyroid? Because remember, guys, whenever it is more thyroid hormones, we call it as hyperthyroidism. When there is less thyroid hormones, we can call it as hypothyroidism. And whenever there is, the level of the thyroid hormones are normal, we call it as euthyroid, right? So that's why it is called as sick euthyroid syndrome. Like, this phenomena is called as sick euthyroid syndrome, which indicates that the patient is euthyroid. Euthyroid means what? Indicates that patient is euthyroid. Euthyroid means what? Simply, it means that the patient have normal thyroid function. Okay, functionality or function. Simply, it implies this thing. So, and simply that's why I always rule out any acute illness in these patients. Okay, so like the normal picture, you can say the normal picture. Uh, the normal picture in sick euthyroid syndrome is one of low T3 and T4, or you can say low thyroid hormone levels, okay, with normal or low uh, TSH. Okay, so that's why we must be cautious when we are going to interpret the thyroid. You can say the thyroid levels in the body. Okay, I will show you a very simple chart. Okay, uh, again a very simple chart and very easy to understand as well. Now, if you can see over here, uh, thyroid stimulating hormone. This is the first test. Whenever we do these tests, we always look the TSH. So there could be three results. Either it will come back as normal, either increase or either decrease. Okay, remember guys, clinical, when I use clinical, word clinical, it means like what we get on clinical history and examination. For example, if a patient is saying he sweat a lot, he's sleepless, he have tachycardia, he eat more, he is losing weight, which means that clinically he have the features of hyperthyroidism. But if the patient is saying that he feels slow, he feels sluggish, he's gaining weight, he eat less, blah blah blah. So clinically, the patient is showing the features of hypothyroidism, right? So now, if you will look over here, for example, when the TSH levels are increased, so what we must suspect, like normally when the TSH levels are increased, so if the thyroid are working fine, so the thyroid level or T4 will be increased as well. Okay, it means the patient have what? The pathology is not in the thyroid, so the patient have what? Thyroid secondary hyperthyroidism. For example, I gave the example of TSH secreting pituitary adenoma. TSH is high, but T4 is low. Now, this is the case of what? Primary hypothyroidism. I gave you the example of Hashimoto's thyroiditis. TSH is high, T4 is normal. Now, this is a patient of subclinical hypothyroidism. What it means, the patient maybe will not show any features of hypothyroidism, but there is hypothyroidism. Why? Because the TSH is increased. Same thing. If the TSH level is decreased, so ideally T4 level should be decreased as well. So, which is a case of what? The problem is in the pituitary. Secondary clinical hypothyroidism. For example, I told you a destructive tumor in the pituitary. So TSH is low, T4 is high, it means the primary pathology is in the thyroid. So it is primary hyperthyroidism. I gave you the example of what? Graves' disease. And when the TSH is decreased and T4 is normal, then it could be subclinical hyperthyroidism, or I told you when T3 can be elevated alone, we call it as T3 thyrotoxicosis or T3 toxicosis. The third possibility is the TSH level come back as normal. So if the T4 is normal as well, so of course it's a normal person. But if the TSH is normal but the T4 is high, so it could be secondary hyperthyroidism. Okay, secondary hyperthyroidism. Simply there can be TSH secreting pituitary adenoma. When the TSH is normal and the T4 is less. So it is secondary hypothyroidism, non-secretory pituitary adenoma. So this is how we see and we try to judge the things. On the other hand, one of the things we check in the patients, I told you, is uh, you can say thyroxine binding globulins. Okay, uh, so simply um, we must be very cautious when we are interpreting free and total T4 levels. Why? Because see, uh, globulin is a protein, so whenever anyone have less proteins in the body, so of course like less of the thyroid can be binded to the protein, but there will be more free form, which doesn't means like the T4 levels is increased, which simply means that T4 is more present in active form, like, or you can say unbound form, right? So now remember guys, the the hormone which makes some difference or which can bring the change in the body is basically the free hormone circulating in the blood which can act physiologically. So for example, there are many factors which increase the total thyroxine binding globulin. For example, in pregnancy. Okay, for example, in anyone who is using oral contraceptive pills, and there are factors which decreases uh, you can say um total thyroxine binding globulin. For example, again I will tell you high corticosteroid levels. Okay, there are many other things as well which can increase or decrease. For example, increase in TBG can be seen in hypothyroidism. Okay, or decrease in TBG can be seen in simply someone who have liver disease, someone who have you can say kidney disease. Okay, like liver failure can be there, or glomerulonephritis in kidney can be there, right? And also thyrotoxicosis. Okay, so these are the cases in which the TBG is decreased. So again, I will go back to the same thing. You can take the example of pregnancy. Pregnancy lead in the cause into increased total binding thyroxine binding globulin. So what will happen? Uh, free T4 level will be low. Free T4 level will be low. Okay, so remember this thing. Okay, so this is how we interpret the thyroid uh, hormone levels in the body. Okay, so thank you so much guys for listening, and I'm just finishing the lecture over here. These are not the only tests which we go for the thyroid gland. Rather, we do also other imagings like I told you. Basically, we divide the thyroid test into two main categories. One is called as the test of functionality, one is called as the test of structure. For example, when you are checking the hormones, it is the test for the functionality, either it is hyperfunctioning or either it is hypofunctioning. But for example, when you are going to do ultrasonography or CT scan or fine needle aspiration biopsy of the thyroid, so that is more a test of a structure. Like it will tell you how the thyroid structure anatomy is, if there is any tumor, if there is any nodule, if there is any hyperfunctioning nodules, things like this, right? So that's why we divide the things in two categories. And of course, like to find the cause of hypo or hyper, primary or secondary hypothyroidism, of course we first of all depend on these tests, and then we go for further testing, like we look for the autoantibodies, or we look for the radioactive iodine uptake scan, or we decide either we have to do fine needle aspiration biopsy, or we have to do like any XYZ test. So we will discuss them when we will study like going to in the imaging topic. So thank you so much guys for listening.